Good day and welcome to Epstein Becker Green and EBG Advisors webinar, Moving to an Integrated Population Health Management Model, the 12th installment in the Thought Leaders in Population Health webinar series. We are pleased to have three fantastic speakers today. Epstein Becker Green's Mark Lutes, who is the chair of Epstein Becker Green and a member of the Healthcare and Life Sciences practice. Sarika Agarwal, Senior Vice President and Chief Medical Officer of Fallon Community Health Plan. And finally, Julie O'Brien, Senior Vice President and Chief Operating Officer of AliCare Medical Management. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint material. At this time, I'd like to turn the webinar over to Mark Lutes.
Thanks very much, and good afternoon, everyone. My pleasure to join you this afternoon. I'm in our New York offices today. I generally operate out of our Washington, D.C. office, and Epstein Becker has been pleased to be part of care management and the managed care conversation for about 40 years now, since we were founded right after the inception of the Federal HMO Act. We have some terrific speakers, as you heard. Just before I introduce them, I might go back on the slide just one place and just ask you to take out your calendar and put one other event on that calendar, and that is our November 20th webinar, for which we've lined up 2 of the leaders in thinking about how employers will utilize value-based purchasing and other techniques on behalf of their self-funded plans. So Laurel Pickering and David Lansky are going to give us the views on that issue from each coast. We're very excited about that and would just ask that you set aside a little time on the 20th to join us then if you have the opportunity. So back to just to build a little bit on why we're so excited by our panel today. Dr. Agarwal, as you've heard, is Fallon Community Health Plan's CMO. Fallon has been a leader in so many parts of medical management and integrated care for a number of decades now. Dr. Agarwal, even before she went to Fallon, worked on clinical integration issues for UMass Memorial. She's been an assistant professor at UMass Medical School, and I think she's just going to bring a range of experience with some interesting populations to talk to us about today. Assisting her is going to be Julie O'Brien, who has got 25 years of experience in clinical management issues. She's a nurse by training, has practiced and done medical management with not only AliCare, but Health Dialogue before that, and a number of delivery systems, Mass General Partners, North Shore Medical, Beverly Hospital, and others. And she's also active thinking about these issues on a national basis, participating in UREX Accreditation Committee and RADSITE's Accreditation Committee. So we're really honored to have Julie to join as well. I'm going to turn it over to Julie in a second, but you'll hear from me from time to time because I've got a lot of questions for the panel. I think we have an opportunity to listen to them on, which is so exciting, is that we have an opportunity to hear from Julie to sort of find us where the what have traditionally been silos of UM and case management, CM and DM, disease management, have been, but then to get the two of them to share this idea of how we might break down those silos and regard these functions as inherently integrated, at least to be most successful, inherently integrated. They've chosen to illustrate that concept for us today in the context of diabetes care management, obviously a disease state that the health system and most of you on the phone care deeply about getting our hands around. So that's going to be an important proposition. And then I know that Dr. Agarwal will have some interesting thoughts, particularly as to how the application works in the context of a dual population. So very exciting. Thanks again for joining us. Julie, do you want to kick it off and set the stage on where we've been in UMCM and DM and where you think we're going to?
Absolutely. Thank you so very much, Mark. It's a pleasure to speak with all of you today and with Dr. Agarwal. Alacare Medical Management works together with Dr. Agarwal on some services which we provide for Fallon Healthcare, and we'll be telling you about some of our approaches to integrated healthcare in the upcoming slides. I'm going to start out with some basics, utilization review. So what is utilization review? It's really looking at the delivery of healthcare services and all of those requests, whether they're admissions, procedures, or treatments, looking at those requests and pairing them against evidence-based criteria and guidelines to ensure that they're medically necessary to actually occur. There's actually 4 prongs of utilization review. They're pre-certification, which is the request for an inpatient admission, a treatment, or a procedure. There's concurrent review, which goes on at the same time, so if that admission needs to be extended or the treatments need to be extended. Then there's discharge planning, and then there's an appeal component. So if any of those things do not meet evidence-based criteria and are denied, the member, the patient, the hospital, or the doctor has the right to appeal that. So we really are looking at utilizing utilization management to ensure that those requests are medically necessary and those that aren't and do not meet criteria are denied. So it's getting the right care for the patients at the right time. Next slide, please. So I'd like to go over some history of utilization management. During the 80s, when utilization management evolved, it had a very bad connotation. Less than stellar reputation is perfect wording for it. People felt it was a barrier. It was put there to deny cases and deny admissions. So fast forward 10 years, we had significant change, not only in legislation, but how we approached utilization review or utilization management. URAC was a company that was created so that independent companies would actually have something to hang their hat on and go out and market that they had a quality service, much like health plans have NCQA and hospitals have JCO. So now independent companies can now get certification through URAC, which is the Utilization Review Accreditation Commission. And they created a certification that dealt with evidence-based medicine and quality to promote a more equitable and evidence-based workflow for people conducting utilization review. And then if you fast forward 10 more years to today, utilization management is really such an intricate part of a larger medical management system. We utilize utilization management in all facets of medical management, and even with the healthcare reform, it's going to be key in the exchanges and managing people and getting people to the appropriate level of care at the appropriate time and optimizing clinical outcomes and financial outcomes. Next slide, please. So some of the benefits of utilization review at Alacare Medical Management is case ownership. And why is that important? It's important because the nurse that's assigned to the case really gets to know the member, they get to know the facility that they're at and the family, and it becomes personal and they become engaged. And so they'll review for eligibility and benefits, and if their eligibility or their summary plan description that they're operating from doesn't have that benefit, they can flex that to an alternative care proposal to ensure the member gets all of the things they need from their benefits for their health care requests. The average return on investment is $5.30 for every dollar spent from Alacare Medical Management. Next slide, please. So how does the role of case management interface with utilization management, because we're talking about integrated approach here. So at Alacare, we actually embed many diagnoses in our system. So when someone calls in for an inpatient admission, that will automatically flag a trigger to case management if it's something that we feel case management should be involved in. And then utilization management team will actually take care of the case. They'll manage it until it gets close to discharge. And then the case manager is hovering until discharge is imminent. And then the case manager will come in and take the case over. The utilization management team will close their end, and case management really comes in to coordinate care for their transition, whether that's to home or an alternative level of care. They'll use community resources. They'll ensure that they have their visiting nurses coming in, their DME coming, and make sure they have a follow-up appointment with their doctor as well as their medications. And that's important because right now we have a very high escalation of readmission management. And if you've read the research on that, they find that the #1 reason for readmission management is medication adherence. So we want to ensure that they are, in fact, getting to the appropriate level of care safely, and they have all the services they need in order to prevent that readmission. And case management also really assists with the over and underutilization of care. We want to make sure that they're getting the care they need and not limiting the care they need. Next slide, please. So case management has a very personalized care plan developed for each member. And why is that? Because every patient presents with different chronic illnesses and will have different goals and different outcomes for their care. We use certified case managers here that operate under the CMSA guidelines. And at Alacare, how we look at case management is we focus on the super utilizers. And what we do is we use the benefit informatics stratification tool, and we use claim data, and we try to take our top 10% utilizers. And rather than having a nurse that deals with asthma, a nurse that deals with CAD, a nurse that deals with CHF or diabetes, we have that one nurse that deals with the whole person and develops that care plan to get them to a better state of health through utilizing short-term goals, long-term goals, and trying to get small gains for them so to motivate them to move further through the continuum of care to get them to a better state of health. Next slide, please. So the Case Management Model Act, this is something that there's groups, the Case Management Society of America is one of them, would love to see this on a federal and state level. And what is it? It's actually utilizing best-in-class professionals, case managers, who utilize cost savings to improve quality of care for their members through empowerment, through evidence-based medicine, through advocacy, and then improve their quality of care, coordinating care using community resources, and engaging the stakeholders. And the stakeholders are going to be the patient, the treating provider, the community members, the families, and promoting change for these members to, again, continue moving them through the healthcare continuum. And case management does this and promotes cost effectiveness through better quality, improved outcomes, and health consumer satisfaction. Next slide, please. So the triple aim slide is one that it's a population health improvement, and it's an article that I'm not sure how many of you have read, but it really is, it deals with an integrated approach, which is the running theme of this discussion today. It's not a new idea, but more of one that's a concentrated, sustained approach to achieve overall better results. So what is triple aim? Triple aim is improvement initiatives through the improvement and individual experience of care, improvement of health of the populations, and a reduction of per capita cost. So we want to improve the cost, improve the care, and improve the population health. And so you'll see that the triangle is the population of health is at the top and the experience of care at the bottom and the per capita cost. And on the right is the factors that influence that. And that's based from the Population of Health University of Wisconsin model. And what they found was health outcomes were driven, and this is kind of stunning, that the health outcomes were driven by 20% of just clinical care. 30% were driven by health behaviors, 40% were driven by social and economic factors, and 10% were driven by physical environment. So we talk about an integrated approach, and all we in the healthcare look at is clinical. We really have to take into account really the whole person and all of these factors if we're really going to have an integrated approach to healthcare. So how do we do that? And how does one motivate people to move them on the continuum? We can utilize morals. I'm not sure how far that will get us, but that's certainly one way of motivating people. We can use regulatory compliance, much like when they put the seatbelt law in and everyone had to wear seatbelts now. We could make it a federal mandate, and that would motivate some people to change. Or we could use financial incentives. Some people do very well with financial incentives. I don't know that anybody knows the correct combination of those, but I don't think it's any one. I think it's a combination of how we get people motivated to move them to a better state of health. Next slide, please. So behavioral change is one of the components that is really difficult to navigate. People are in this state because they've had these health habits for many years. They do certain habits that create worse conditions for themselves, like smoking, drinking, lack of exercise, and poor diet. At Alacare, we use the Prochaska model, which is the readiness to change. And we find that people are ready to change when they've had a major event in their life. And case management, if they can get in, and that's part of discharge, if they can get in then, they can really motivate the members or the patients to have some significant change in their life. If not, we do it through education and encouraging patients to try to get them to that goal of a healthier lifestyle through our short-term goals and our long-term goals, and engaging them not only with us, but with their stakeholders and their family and their primary care physicians. Next slide, please. So I'm going to start out with some statistics from the CDC just to set the platform for diabetes that we're going to be looking at, because it's such a widespread chronic illness in this country today. It impacts 25.8 million people, which is more than 8% of the population. It also stated that over 7 million of these people affected by the diabetes are undiagnosed. It's the 7th leading cause of death in the United States, and we know that diabetes is a gateway to other contributors and other comorbidities like heart disease, stroke, kidney failure, limb amputations, and blindness. In addition, they say 79 million adults, or 35% of the entire population, are pre-diabetic. So think about that. That is a huge population that this disease is affecting. Next slide, please. And if that wasn't enough, the financial burden in 2012, it was reported that $245 billion were spent on diabetes. 176 billion of those were in direct medical costs, and 69 billion was attributed to reduced productivity. Now think about all those that aren't reported yet, and think about all those ones that haven't had any of those symptoms yet, and the cost that would be astronomical if we added those on top of the $245 billion. Next slide, please. So some of the treatments for diabetes would be diet management for type 1 and type 2, exercise and lifestyle changes for type 1 and type 2, insulin injections for type 1, and the CDC strongly recommends to have somebody that can facilitate care, the gatekeeper, and that's where case management actually really helps in the diabetic arena. They can coordinate care, they can ensure safety, they can utilize community resources, they can negotiate, they really can help this person move to a better health state with intervention, monitoring, and collaboration with the caregiving team. Next slide. So innovative management of diabetes can help reduce a patient's risk of developing complications from the disease, and we've gone through that of how we make them feel better. Next slide, please. So I'd like to tell you about a case study that we did at Alacare Medical Management. One of our groups had a large amount of diabetics in their population. So we used our stratification tool, which is benefit informatics, and we combed through to pull out all of the potential diabetics and those that were in active diabetes management at that time. And what we did was we told them all that if they enrolled into this program and became active members of our disease management program under diabetes, then we would supply to them free access to medication and free supplies. So they all had to go through their psychosocial assessment and clinical assessment from our case management team, which we did. And from there, we created care plans for each one of them. Now, the reason this is important is because if you remember what we discussed earlier, the reason for readmission management was medication. What's the #1 reason that we have readmissions? So if we gave these members free access to their medications, then perhaps we were pulling away one of the barriers of why people don't get their medications. So we wanted to test that scenario out to see how that would work. We also decided, and we heard from the diabetic population, that they can't afford their testing strips for the glucometers. So we said we would give them those supplies. So we're going to waive all the copays for their medication supplies. We'll take that on, and then we're going to see how they do. So a year after we implemented this case study, 60% of the members actively enrolled in the case management process. A year later, we saw a 20% decrease in readmissions. We saw an increase in their short-term goal gains. 95% of them were in a walking program. We saw them testing their glucose regularly because they were able to get the test strips. And today, we have a retention rate of 95% in that group, which is remarkable. So we do have the ability to implement interventions, and we do have the ability to push them through to a better state of health and assist them in the continuum of care. Next slide, please.
Julie, it's Mark, just before you go back to, and I'm sure Dr. Agarwal will be weighing in on them, just repeat for us, if you will, what you consider to be the sort of top 2 or 3 drivers of that progress.
Of that case study?
Yes.
So I firmly believe that the top 2 and 3 drivers are that we waived their copayment for medication, #1. #2, we waived their copayment for the tools or the supplies to assist them in the management of that disease. And #3, we gave them access 24/7 to a nurse, case manager, that would assist them through this continuum. So those would be the top 3 drivers.
And what was the utilization, just taking those in no particular order, but what was found in terms of how they were utilizing the case management nurse?
So they utilized the case management nurse. If they couldn't get their medication at the pharmacy, they would call and try to ask if there was any way they could help them get them to them. So the case manager would intervene there. If they couldn't get their supplies, the case manager would intervene and try to see how that they could get their supplies for them. She or he really was the navigator, the care component, the gatekeeper, the communicator for them, and try to assist them to be successful. Okay, so on the next slide, engaging consumers in health and wellness. As chronic disease continues to drive up health care costs, moving towards a preventative care mentality will not only improve the health of America public, but also boost the health of our economy, which is really what we're trying to get to in the integrated health approach. And at this time, I'm going to move the presentation over to Dr. Agarwal.
Thank you, Julie. Can I just have the next slide? So just to, give you a little story about when I was on the provider side and I was running clinical integration, to go back to the triple aim slide of Julie's, one of the things that continued to frustrate me was that we made so little difference in just giving people medications and changing their medications. And that slide illustrates why. It's because clinical care really changes only 20%, it only makes a difference in 20% of population health management. It's the environmental, the behavioral, and the socioeconomic factors. And that really, made a difference in how I thought and what I do now and how I work and how I really address population health management. So to go back, the U.S. health care costs are at an all-time high, and everyone knows this, but it bears worth repeating, greater than $2.4 trillion annually. And 70% of these costs are related to behavior, so one thing less that we can blame our parents for, 30% related to genetics. 20% of the population generates 80% of these costs, and all these costs are spent in chronic disease progression and end-of-life care. So really, we are spending on sick care rather than health care. So we really need to shift this curve to value, this cost curve to value, and that means we need to find those at-risk patients and really concentrate on population health management. So 10,000 baby boomers every day, rising acuity rates, higher cost of care, and higher expectations of care. Next slide, please. As the acuity of illness rises and the intensity of illness rises, the patient gets bounced from door to door, and you can see the spectrum of care is vast. Next slide, please. As are the barriers to care coordination. The result is fragmented care and inefficiency of service delivery. Next slide, please. Who are the populations that are at the greatest risk? The frail elderly, the poor, whether they be children or adults, the high utilizers, the mentally ill, the abused or abusers, and the patients with high disease burden. Next slide, please. So how do we identify these individuals? The members are identified, the patients are identified for population-based management programs through multiple sources. We get referrals from providers through customer service. Members self-refer themselves through case management, through health needs questionnaires, through health risk assessments. Our duals are all managed, and we'll talk about these a little later. However, our other lines of business, our mass health, our Medicare, our commercial lines, our opt-in voluntary programs. And we have various pathways through which they get managed. Next slide, please.
Dr. Agarwal, I'm going to slow you down once in a while. One of the questions we're getting online from a listener was asking about the size of the populations. Could you give us a general idea how many were in these study cohorts?
Can we go back?
Sure, we'll go back to the, yep.
So our dual over 65 population is about 4,000 strong. Our dual under 65 population is a demonstration project and is about 7,000 strong, and they're all managed. So because the case management is required for all. Our mass health population is about 30,000 lives, and we manage a percentage of this population. They go in and out, and it depends through the various pathways. And I would say a few hundred because they opt in and out. Our Medicare population, about 500-600, and we have about 15,000 lives. And our commercial population is about 160,000 lives. And so, and I'm not sure about the exact percentage because we have various programs for a commercial population for disease management, wellness programs. So there's a various percentage in the different programs. And there's a slide ahead which actually gives us a percentage.
Thank you.
Can I go to the next slide? Oh, sorry, the slide previously. Okay. So an integrated approach. An integrated approach to complex conditions management includes chronic disease management, wellness and health promotion using a case management health coaching model. We use a segmented approach to the population using a health continuum model and member clinical and risk attributes. Can we go to the next slide? An integrated approach. Fallon uses Optum Analytics for population segmentation. Can we use claims data, clinical data, socio-demographic data, and care management data. Claims and enrollment data is a must as it provides utilization costs and other basic information. Pharmacy data is also important because it gives us gaps in care and drug interactions. Pharmacy data is especially important because it is timely for example, in our Medicaid population, I will use it to help us locate the members sometimes. If they are in the ED and we get a daily feed from the pharmacy, if they get, for example, if they get a prescription in the ED, we can locate them, and then we can actually, you know, case manage them. We can actually give them education about an ED diversion program. So pharmacy data, it can be very timely for us. Clinical data, such as lab data, is invaluable. Our clinical staff have EMR access with some of our important provider groups. Care management data and socioeconomic data, such as health risk assessment, is also important, especially in new patients, because as you know, there's a lag in claims data. And predictive modeling is very important as part of our segmentation strategy. It predicts future cost, future hospitalization, and future chronic catastrophic conditions. Next slide. So this sort of gives us the program pathways. We stratify our members, our patients, by individuals and by diseases, by chronic conditions. We stratify them into our care coordination, our care management, our complex case management, our wellness disease management, and our behavioral health intensive case management programs. Our complex case management uses a nurse case manager. This is usually involving complex diseases such as ALS, cystic fibrosis. The nurse case manager usually provides coordination of care. These members have experience of critical event or diagnosis. Care management is usually involving the nurse case manager and a social worker. This is involving members who have diseases such as COPD, after surgery, a new diabetic. They require assistance of a clinician to help identify resources, appropriate care and services. Care coordination uses a navigator, usually a new hypertensive, to make sure that they have referrals to appropriate resources. Our behavioral health intensive case management is for individuals with complex comorbid conditions. We have a behavioral partner called Beacon that helps develop crisis plans for our enrollees. Our Beacon case managers sit with us physically, and they help identify resources in the community as well as connect our members with providers as needed. We have an online healthy health plan for our wellness disease management with online programs as well as online tools, in addition to telephonic disease management. And our disease management case managers as well as our case management managers are all integrated. They all work along with our utilization management nurses on the same platform, which is CaseNet or TrueCare. So they're all integrated, and each one can visualize when the other one is working on the same member.
Is there any difference, Doctor, just before we leave this slide, some of the questions coming in are asking, do you inherently differentiate between the over and under 65 populations, or are you doing your population segmentation sort of agnostic as to that distinction?
No, we do not differentiate. No, our dual program is completely different because we have to follow the CMS NCQA guidelines. For everyone else, no, we do not differentiate.
Thank you.
And I'm going to talk about the dual program as a separate program.
Right. And there's natural curiosity among the listeners also as to, relative costs of the different combinations of services. So as you go along at different points, if there's anything you can do to address the resources required, the cost of those resources,
certainly,
among the stratification would be helpful.
Okay. Maybe we can address that towards the end. Is that okay?
Great.
Okay. So can we go to the next slide? Okay, so I thought we would talk about the dual program because really this integrates all the sort of the social, behavioral, medical needs together, but it also integrates the CM, and DM, the utilization management, case management, disease management, sort of nicely together. And we work really to bring these models of care together, not only as a model of care, but also together in the delivery system, because the providers on the clinical side are trying to bring these programs on their side, and the health plans are trying to bring these develop these programs on their side. And so the elder services are trying to do this program on their side. And so one of the things I found was this member now, sometimes of course there's paucity of touching the member, but at other times the member is being touched several times. So they're leaving the hospital, the elder services is calling them, the health plan is calling them, the provider office is calling them. And so one of the things we tried with this program is we coordinated with the provider systems as well as with the health plan. So really trying to coordinate care in every way that we could. So who are the duals? They are the Medicare and Medicaid eligible. They're really the most vulnerable individuals served by the publicly sponsored programs. They form the vast majority of the spending of the two programs, about 9 million duals, $250 billion in spending, and most of it is in acute care. They have a higher rate of catastrophic illnesses, developmental or intellectual disabilities, and mental illness. They have diverse needs and really need targeted care coordination and integration of their services. Can we go on to the next slide? And so they are the most vulnerable individuals of the Medicare population. They are the poorest and the sickest of the Medicare beneficiaries, the lowest income, greatest disability, and greatest mental impairment. Next slide. So we have two programs. On the right-hand side is Navicare, which is our over 65. This is the Fallon program since 2010. In Massachusetts, the dual over 65 has existed since 2004. So this is a well-established, thriving program. We have about 115,000 duals in Massachusetts. The left side is the Fallon Total Care program. This is the 21 to 65 program, 64 actually. This is just a demonstration project that started in 2013. So we really are just in the first year in this demonstration project. As you can see on the right side, the over 65, about 65% of the duals are in the community, and they are just one step away from being in the nursing home. So our goal in this program is keeping them away from the nursing home. They have a large number of them have comorbid illness, diabetes, COPD, coronary artery disease. Going back to what, Julie's diabetes project, very important to, again, huge number of comorbid illness. On the left side, 70% of them have a behavioral diagnosis, with 30% of them with serious mental illness, bipolar disorder, schizophrenia, 30% with substance use, and again, comorbid medical diagnosis, asthma, diabetes, heart disease. So really people who need targeted care coordination, disease management, case management, utilization management. Next slide. So again, we are trying to coordinate care, integrate medical behavioral care, keep them independent, and this is important, collaborative provider relationships, as I mentioned. Really, my ultimate goal is to delegate the care management to the providers. The slope is that we start working, with them, we embed these care managers in their practices, and hopefully then they take over, because I do think that it works best that the providers take over the care management for these patients. I think that's how and we've worked very well with this model in several of the provider health centers. We increase access and quality of care. We manage transitions of care. That is big in this population, and of course, increase cost effectiveness. Next slide.
Julie, just before we leave the last sentence, may be part of what you're going to get to in the model, if you could address the qualifications, the training of the folks that are embedded.
Yes, I'm actually going to come to that.
Great.
With a model of care. So both the programs, and so this is really important, you know, in terms of all the members, all the patients are considered high risk and are managed. So every one of them is managed. The model of care really follows strict guidelines, and they have standard structure and process requirements, and we are audited on them. They follow complex case management guidelines, care transitions, quality guidelines, and really they're based on integration of medical behavioral needs and social needs. So we have what we call the interdisciplinary team with the member, the primary care team, and the navigator. The navigator is really the care coordinator or the quarterback of this team, and the navigators really range from they could be a home health aide, they could be a bachelor's degree in social work, they could be, for the elder in the over 65 population, they could have worked in the nursing home. In the under 65 population, they could have worked you know, with the substance use population. So really, it is their experience that we hire them for, because it is their work with the population that's very important. This population has a lot of different ethnicity, different literacy, different, you know, a lot of language opportunity. So we really want to hire these navigators because they are the key. One of our key survey questions for these navigators is they are the relationship builders for the PCPs and the member is, you know, do you recognize your navigator? So it is important that this relationship be strong. So we really hire them, you know, for that that identification with that member. So their education and qualifications range depending on which population they work with. The other members for the elder population, there's a geriatric support social worker, there's a behavioral health clinician. These are LICSWs, and they're part of the team. We have a pharmacy technician that's part of the team. We have the LTSS, which is an independent living long-term service support worker. We have social workers, and of course the various other care collaborators in the community that work and are part of this team. Again, everybody works external as well as internal with that care management platform. So they all work in that platform, and so everyone is looking and writing into the same record. Alacare, and Julie will talk about that. They are part of our over 65 program, which is Navicare. Julie, do you want to talk about that? You know, because they're an integral part of providing the 24/7 care, which we think is really important as part of our continuing the continuum of care.
Sure. So in the effort of having an integrated approach, we actually provide services for Fallon for this population as well as some of their other populations. But what we do is Fallon gives us access to all the information. So when these members call us, we have the ability to look in and see who their navigator is, see what happened today, see where we need to get band service for them. We can complete their care or wrap their care for them because we have access to all the information, which just is another facet of the integrated approach to healthcare by having us double back and fill in for them and answer all the medical questions that come up when their providers aren't available or their navigator isn't available.
So again, this just illustrates kind of what, I was saying earlier in the model of care. The navigator is our quarterback, arranges the meetings, helps with the establishment of the individual plan of care. Our plan of care is member-directed and member-driven. Every member visit is face-to-face. And so the unique aspect of this model is that our case managers for our Navicare model are not just case managers, but they actually are also utilization managers. So they're trained in utilization management. And one of the reasons we did this was because they have they're so unique in that they know every aspect of this member and this patient and their home environment and their caregiver relationships and their needs, that I thought when they had their care transition, they would know if they were ready, say, to go from the SNF to home or from the hospital to home. So they should be the one who should make that authorization, whether they were ready to make that transition. So they were trained to do utilization management. Also, the navigator, we thought, since they were doing face-to-face visit, who would be better to help along with the nurse case manager to do some of this disease management and gaps in care and some of this self-monitoring and education regarding the disease. So we actually have trained them to do some of this self-monitoring and conversation about their disease and along with the nurse. It's nurse and PCP driven, but they help that along with our quality and disease management program. Next slide, please.
Well, could you give us some idea as to population assigned per navigator and what's the sufficient scale at a provider site to make this work?
So, so the way we do for our, so at our health centers, we essentially have, we usually require, about 100. We tell them to have about 100 patients before we start embedding, navigators and nurse case managers and behavioral health clinicians. Most of our health centers actually have their own behavioral health providers who are usually psychologists, but our health clinicians do not provide clinical care. They are facilitators, so they do their assessments, they do clinical assessments, and so they're, again, facilitators. All our model are facilitators. So I think, but they follow the mental health and they work very well with our behavioral providers. So, we have, usually they're embedded in the sites, except when they do home visits. So it works really nicely. They work in their EMRs, and the providers can task them, but they're also physically present. When they're not physically present, they do accompany these members to their provider visits. So even if they're not embedded, the provider can talk to the navigator, about the member. So even if they're not embedded, that's of additional value. So sometimes that can be of additional value if they, just being able to talk to them.
Got it. That's helpful. Thank you.
Can we go on to the next slide? So I just wanted to mention this. This is a pilot that we're doing with HealthSense technology. It's a remote monitoring, and we're just about a year into this, and the results are encouraging to see if we can reduce the rate of utilization and decrease, again, same thing, keeping the members at home, avoiding nursing home placement, multiple sensors, including toileting, sleeping, transfer activity. We have developed intervention protocols for these alerts using the RNs and the navigators, and seeing if, we can get MD appointments from these alerts, which results in medication changes and maybe reduce ED visits and so forth.
When you say that results to date have been encouraging, what sort of indicators are you looking at?
So, for example, you know, a toileting alert. So it's on the toilet, and, you know, say a person has been used the flush multiple times, and so it goes to the center, and the health note comes to the navigator or RN, and they call the patient, and they say, okay, do you have any symptoms of urinary tract infection? Is there burning or whatever? And they say, yes, you know, I feel like I'm going more often. So they call the MD and give the symptoms. The MD then prescribes an antibiotic for a presumed UTI.
Right. Is there another example beyond UTI where it's
yes, so for example, it could be that a COPD patient, so there's a bed sensor, you know, and a patient, another patient, I guess, was having an COPD exacerbation, and was more restless, I guess, and health note, again, same thing, navigator or RN called. Initially, we had the navigators call, and then we switched to RN, and we're still working what would be the optimal way. Should we direct questions? Should we ask open-end questions? You know, there's a lot of work being done on this. And, you know, so we asked questions, and they said, yes, they were more short of breath, and then we actually had the patient evaluated, found out that, you know, there was more hypoxia than usual, and was put on a prednisone taper, and resulted in medication change.
Great.
Can we go on to the next slide? And so this is really not for our dual population. This is really for our Medicaid, for the rest of our population. And this is, I recreated what we found was, in order to get our CM and our disease management workers to, you know, all our staff to sort of work together, we thought we should physically maybe put them together, and our, you know, and disease management, and put them into pods. So we created, and it's interesting because a part of my clinical integration work as a provider, I created pods for the providers, and so I thought, we'll create pods for the nurses. And so this is what we created, and it's actually worked very well because, you know, to Julie's point, you begin, the idea is that you begin case management the minute the transition happens. The first day the patient gets admitted to the hospital is when the case management begins, because you start thinking, what does this patient need? Where is this patient going to go? You know, are they going to go home? Are they going to go to the SNF? Where are they going to go? We use the LiveSafe tool, which is previously the Senior Metrics tool, now the LiveSafe from NaviHealth, which integrates physical cognitive assessment and gives us an assessment whether the patient would be transferred to the home or the SNF. Our nurses do participate physically in the concurrent reviews in the SNF and in the family meetings, and I think that has helped in reducing our SNF length of stay, especially for our dual program. Next slide. And again, this is in our Navigator RN duties, and I'm sure this is, you know, this is standard, but I thought it's worth repeating. Med reconciliation, ensuring that everyone in the primary care team is informed that there has been a transition of care, making sure that there's a follow-up appointment made for the member when there is a transition of care, follow-up with the member within 2 days. And this 2-day window, we've looked at this because there's some hospitals that actually are calling. They have automated phone calls to the members in 2 days. So we're actually looking at this window and seeing if we should change this window. Again, teaching the member about their disease when they go back because their medications have changed, and ensuring that the primary care team meets again to reassess what the member needs. Next slide. safe discharge, reassessing the needs of transportation, med reconciliation, education, training, transition, and auditing of the transitions. This is really important. We found we need to constantly assess the transitions, making sure that our team is really adhering to our workflows and documenting everything in our care management platform. Next. So I thought we'd just talk quickly about our Navicare, which is our dual over 65 member. This is a 77-year-old gentleman who has multiple comorbid conditions, was hospitalized multiple times in the emergency room. Very common classic ER member who a lot of you may have seen, multiple hospitalizations due to pneumonia, and really the member wishes were that he wanted to enjoy the life he had left, and really it was symptom management that he wanted, and he wanted to live independently. And the Navicare philosophy is to maintain the member at the highest level of functioning in the least restrictive setting. In this case, the member wanted to live at home for as long as possible. So the team met together, and what we tried to do was, whatever we could do to keep this member at home to avoid getting this member to the nursing home. We provided transportation for this member to the specialist. We actually have a nurse who's trained in end-of-life care who talked at length with this member. We implemented home services. We had this member talk to the behavioral provider. We had better management of the member's anxiety. We had a psychiatric nurse actually work with the member at home. We had discharge planning meetings attended by our staff with care plans aligned with the member's wishes. We had education done with the member and caregiver. And essentially, we were able to avoid hospitalizations and ER visits with the member's anxiety and dyspnea controlled, and the member was able to be independent at home with support for several months after. So can we go on to the next slide? And these are just some of our results with Navicare, just with our acute admits, our readmission days, our SNF days, and our average length of stay, our RAF scores. We've done fairly well. We've been able to work on all of our metrics, and we constantly try to improve. Can we go on to the next slide?
Which of those, Doctor, are most challenging?
Can we go back? Yep. Do you want to go back? Yep.
Yeah, I would just ask you, with respect to each population, which is proving the hardest to move the needle on?
I mean, the thing that we work the hardest on is really, I mean, the 30-day readmission is tough in this population, of course. The SNF days, again, are hard. A lot of these patients are ready to go to the nursing home. Our challenge is, to get them back home. A lot of them, again, because, that is definitely challenging.
Okay.
So.
And when I think about the parts of the program, as a non-clinician, I'm sort of tempted to stratify it as you're putting a lot of resources in transitions, and then another set of resources in the sort of home monitoring to avoid the hospitalization, the ER visits, or SNF admissions. From an emphasis perspective, or back to some of the questions that were coming in from listeners relative to resources, how much do you think you're spending as a percentage of the total spend here on each of those two buckets, or in each of those two buckets, transitions versus for the home monitoring? side of things?
So the home monitoring is just a pilot. It's a small pilot. So it's not across our Navicare program. So we have yet to see, it's yet to prove that itself. So
yeah, and I didn't mean to confine that to just the utilization of eNeighbor, but just all the navigation that occurs post-discharge, the care management that occurs post-discharge.
Right, okay, so I would say that our whole model of care is really all comes under our administrative expenses, say we have 3 to 5 people taking care of each member. If you consider it's a nurse case manager, a navigator, a behavioral health clinician, a pharmacist, and the geriatric support social worker really belongs to the elder services, so that's really supported by the state. So the nurse case manager is also the person doing the utilization management, remember? So that actually is increasing her workload, and she is also the person who goes to the SNF. So we're actually, we have educated the staff, so they're forming, so we're actually using them, so they're now working in 2 ways. So in a way that is a saving because we don't have a utilization management nurse doing that. So that is almost a saving. So, you know, we're trying to educate them, and then the navigator and nurse case manager are doing some of the disease management work there. So that the educators in the disease management have to do only the high-risk patients, and some of the day-to-day coaching can be done, the gaps in care can be done by the navigator. So really, we're trying to have everyone work to the top of their license here. That is what we're trying to do, because I really feel that there's a lot that can be done by each of, these are highly skilled staff, and I feel like we were not using them to the best of what they could do. The HEDIS outcome measures, as you can see, we are, improving, year by year. So we're definitely doing well with advanced care planning, medication review, functional status, pain screening. Next slide. These are our rounds that we do. We are very, very committed to discussing with all our staff. We have didactic rounds on various topics for our navigators, our nurses, on the diseases. We have inpatient rounds with the medical directors, SNF rounds. In the provider groups where the nurses and navigators are embedded, they actually have rounds with the providers. We have behavioral health rounds with the behavioral health clinicians. We have ED utilization rounds. So there's a lot of discussion on these patients that are at high risk. Thank you.
Quite a few questions. I'm going to begin with them. Julie, chime in as appropriate here. One of the more recent ones was a question just as to overall impact. And as you think about the types of services that you're providing, how do you think the skew of those services has evolved? Clearly more in the case management and navigation, you've got an investment there. Is that, in your view, reducing spend in any other categories, and DME and rehab, and or just in inpatient stays? What's your thoughts about that?
Julie, do you want to start and I can go chime in, or?
Sure. I think that one of the things, and which is really the theme of this whole discussion, was integrating them. And Sarika is absolutely correct in the fact that the case managers actually can do a lot of the other pieces of the care that's derived that was carved out initially. So they can do the utilization management and the disease management. So I think she's right. There is a lot of savings there and a lot of collaboration that goes on, and they can interface all of them together. So I think that, you know, overall, again, it's a transition and it's a movement of breaking those silos and interfacing them and integrating them. And we're only in the beginning stages of that. And I think as we move forward, utilizing not only technology but people, you're going to see a much more integrated approach in the very near term.
So I actually do not think that there's decrease in the DME, and I actually think the services increase, but if you think about where the spend is, the spend tends to be in the inpatient. That's where the spend is. And so I think in order to decrease that, because that's where, you know, it's the most expensive spend, and, you know, I think of least value. So if you're trying to bring it where there's value and quality, if you increase home services and DME, if that can bring it to a place where the patients want to be, which is home, via DME and home health aides and homemakers, then it's okay for those services to rise and for their, you know, for them not to go into the hospital. And so really that's what we see in the population.
Great. We had just a nomenclature question. Someone had asked you to define the acronym PCT and CER.
Oh, sorry. PCT is primary care team, and CER is centralized enrollee record, which is basically our care management platform, which is the CaseNet True Care platform, which is the case management that we all work within.
And how long have you been on that platform?
We've been in that platform for, I would say, 2 years now.
Uh-huh. And just, again, for the sort of uninitiated like myself, I hear that that everyone has access to it and you know, common record, et cetera. Can you translate that? What are the things that you think most immediately come from that in terms of benefits for the patient or the efficiency of the care?
So for example, you know, a nurse sees, just very simply, a nurse sees a patient, does a health risk assessment, which is, you know, assessing them for all their physical needs, et cetera, then discusses it with the primary care physician, and they come up with a plan of care after talking to everybody. They then, there's a standardized template that's in this care management platform, the documentation of their medications, kind of like an EMR, you know, their drugs, their allergies, et cetera, past history and so forth. It's all put into that care management platform. If the patient gets admitted, the records come in from the hospital in there. The UM nurse gets in there and puts in the authorization. The case manager looks in and maybe picks up that patient for something. Say the patient smokes. The care management may pick up the patient for, everybody can look in there and sort of follow that patient at any particular time. The geriatric support social worker who is working at the ASAP in, I don't know, several miles away can log in, and the geriatric support worker 10 days later goes to see the patient for some other reason, then goes back to her office. She logs in from her office and then writes into the program that she logged in and decided that this patient needs a homemaker to prepare meals 3 days a week, and so she puts it in, and then the navigator looks at that, authorizes that, and puts it in as an authorization, and it's authorized for the patient. So it's all done through this platform, and it's all documented there so everyone can see within that platform.
So even, let me just add to that, so even us, when we get a call, we can actually see if somebody calls about a medication they were prescribed that day, we can actually look in and see exactly what the medication was and respond to the questions that the family member has.
Right.
So it just makes it accessible so that we know exactly what went on that day with that member so we can round up that care for them.
And the entire hospitalization that the patient has, there's daily records that are being written on the patient in that. So physical therapy notes, everything. The only thing that's really lacking right now is it's not really talking to the EMRs. And that's because EMRs just were not sort of built yet to do that. And I'd love for that to happen, and they're working on that. But that would be the best, that would be great when that happens. So.
Right. Well, what, in your ideal world, what do those feeds from the EMR look like?
I'm sorry?
In your future state there, what would you see the feeds from the EMR being comprised of?
So we are looking at right now what we call ADT transfers. So we're going to pilot this, which is basically the admissions, discharges, and transfers, all of those things happening. But the EMR, I mean, through the portal, I can imagine, or what we, DB Motion, that there would be transfers, because our nurses are able to, work through, they are able to work and look at the EMR. So it would be nice if all the information here, the health risk assessment. So remember, we talked about what the providers don't have is the socioeconomic, the socio-demographic data. They don't have the nurse's home risk assessment, the environmental assessment for the patient's risk for falls. They don't get that. And they can get that as a paper which they can scan in. But how wonderful it would be if that data just flew into their EMR. That would be the ultimate, that they had their clinical data, they had that health risk assessment data. If it all just sort of, it was interoperable, that would be my perfect world.
Right, right. Well, it sounds like that's probably something we should devote a segment to in this series at some point, because there's always been an interesting breakdown between or chasm between the EMR world and the care management systems that payers may be operating in. That, as you say, integrating or crossing that chasm is going to be, important as we go forward here. Trying to get at a couple other questions that we've been getting from listeners. Wanted to ask whether you had done any work to try to assess any potential decrease in additional chronic conditions taking hold or becoming an issue in your assessment of the clinical efficacy of your work here. Or is that a bridge too far so far in terms of being able to say we've avoided the onset of, by doing X, Y, and Z, we've avoided the, some degree of complication or the onset of some other condition?
I mean, substance abuse is a huge, huge problem for us, as is depression. And we are constantly looking for ways, to work with the population and look for ways that we can better our case management for this population. So, we are looking for community resources. We're looking for, and we continue to look for solutions. And it is difficult because a lot of the population does not opt in, because remember, this is member-directed. They have to want to participate in these programs. They have to want to, and it takes them a while to want to. So that is a big challenge. You have to, there's a lot of motivation involved in there, so that is a constant challenge for us. The member engagement is, as everyone knows, is a constant challenge, and that there's a lot of tools out there, and there's so we have a Healthy Health Plan that's an online tool for our members and their dependents, and even for our employees, engagement is a challenge. So we offer reimbursement up to $200 for this, and engagement continues to be a challenge despite reimbursement. So it's improvement, but that continues to be an issue.
Okay. And we've just taken you back to a much earlier slide where you gave the listeners an opportunity to see the different trends of populations that you're running this program across. Right. So it makes sense to go back to it, and maybe you could I'd like to go back to the question of costs and anything else that you think that would be better summed up in the context of the different segments of population that you're challenged to work with here. And it goes also to the very interesting fundamental proposition of running a sort of a unified program against these different memberships. So anything more you have to share about that would be helpful.
So, for some of these programs, we have some very specialized programs for complex case management. So, for example, for cancer, we actually have a specialized complex case management program for the commercial and Medicare population that is exclusively for the cancer patients. And part of the reason we went with a vendor for that is because, so we have a vendor for that is because that had a whole component of requiring, there was practice variation in the oncology protocols and required, oncology nurses and oncology medical directors, and we didn't think that we could bring that in-house, although we are considering now bringing that in-house. And for the substance use, we actually do have, for the very, very high-cost substance use, we actually have just for the commercial population, we actually are, again, using a vendor, which is a very good program, but we have not been able to enroll enough members into the program. It's just been difficult to get people to participate in the program. So there's continual challenges, for the various programs. For the Medicaid population, we're actually doing well with our health risk assessments and enrolling people. Like I said, we've developed the ED diversion program by identifying a lot of these members through our pharmacy data. If a prescription has been, if there has been a prescribed medication in the pharmacy, we identify these members and then re-educate the members. And so we are now looking at telehealth program for our Mass Health members. So, we're continually looking at, our case management, disease management, utilization management program across these various, the different populations.
Right.
And where are we getting an ROI, and how are we, doing with them?
Okay. And maybe another way that it might be expressed, do you think of the cost of the program as a percentage of premium?
Yes. as a medical
expense.
Is there
a way to talk that, any way you'd be comfortable in talking about from that perspective?
So definitely, so the cost, definitely the cost of the program, is definitely a percentage. Definitely it's a medical expense. We definitely think about that. It does need to drive an ROI, absolutely. And the continual challenge is we definitely have that. We also need to drive down utilization. We have those continual challenges. Whenever we create the model of care, we do have to, sort of build all of that sort of into the program.
Okay. We suddenly got a flurry of questions. The same question, I think you addressed it earlier, but I want to restate it because people may have missed it. A number of people are focusing on the caseload for the navigator, so maybe we could spend a little bit more time.
That's always a question I get. Okay, everybody wants to know the caseload. Because it's supposed to be the secret sauce, but there really isn't any secret sauce. So, so the caseload varies, again, depending on the population, and to be very honest with you, it really has depended on the provider groups that we've embedded the members in, and it depends on our navigators and the nurse case managers. So we started off with a certain ratio, and then we found that one size did not fit all. And so certain health centers that we embedded our managers were really high-functioning health centers. And like I said, that we found that for 100 patients, we were able to embed a team of navigator nurse case managers, but that always was not the case. Sometimes you needed a smaller number and a greater number of navigators, nurse case managers, depending on the patients, because they were much sicker, more illnesses. And later, as they got better managed, you could actually cut down on the number. So it's really, really dependent. So.
Okay. So if I'm, did that stratify at all across the programs, or was it simply a function of the comorbidities, the complexity of the patients, whatever program they came from?
Oh, it stratified. So we had, for the dual programs, there was a certain sort of percentage that followed our model of care, that we were guided by our guidelines. And then for the other programs, it really depended. It really again depended on the caseload and the what the caseload of the navigator and nurse case managers, who they were carrying.
Okay. All right, that's helpful. Just thinking, going back to the diabetic pilot, Julie, anything more you could tell us there? We've got some questions again just about the number of members in that cohort, cost of that intervention, whether or not the case managers were being utilized more than once. Anything in those categories you can be helpful with?
Sure, and I just want to speak a little bit to that caseload too. I think it depends on the severity of illness and the intensity of the cases. So that really varies your numbers whenever you're doing caseloads. Back to diabetes, on that intervention, that was a 5,600 membership group, and the The case managers that were assigned to that were assigned not strictly to that alone, but they had a certain caseload, if you will, in that group for a certain population. And again, we base that on severity of illness and acuity of illness and intensity of services. So the cost overall in our case management, this is over our commercial population, it's $5.60 for every dollar spent. But on that project alone, I'm not sure that we actually whittled down the actual cost of the case management intervention that we did with them. But we did. It was a pilot project. The group liked it, so they're going to continue to roll that out.
Dr. Agarwal, anything on that you want to add?
No, that's, I think, pretty much echoing what Julie said.
Okay. I think we've come pretty close to the end of our time, though the questions seem to be rolling in. I'm going to ask Kirsten to take over in a moment and make sure everyone understands how to access the materials from today, and invite you again to join us on November 20th for the session with the business groups on health. Again, huge thanks to Dr. Agarwal and Julie O'Brien for their contributions today. They've identified a number of very important notions that I think we'll continue to try to pursue in this series, and maybe ask them to return to us from time to time with updates on this model of care. Thank you again.
Yes, thank you, Mark, and to our wonderful speakers. We do appreciate you joining us. And to everybody who has been in our audience this afternoon, we do appreciate it. And we will conclude today's webinar now. In approximately 2 to 3 business days, Epstein Becker Green will communicate via email the availability of both the webinar recording and access to these PowerPoint materials. Thank you all so much.
Thank you.
Thank you.